knowledge and improve outcome via research. Dr. David Cameron.
Thank you very much. I'm very flattered the audience is still here. They must have heard enough of my voice by now to need a cup of coffee. Let me try and talk for the last few minutes about, in a sense, how we use trials to advance research. So a little bit about how we design trials and conduct them, and what we do with the results of the trials. So if you want to be a good trialist, I think you've got to know why you're doing it. If I sit in a clinic with a patient and try and persuade the patient to enroll in the trial, and I have no idea what the trial is about, no idea what question it's asking, and don't really think it's worth doing, the patient, whatever words I use, the patient will hear me. And in my experience, actually, the emphasis, or rather the importance that we put on the trial question has an influence as to how willing patients are to go in the trial. That's not because I'm forcing them to, but if I can sell the trial question, it's easier for the patient to say, actually, I understand why this trial is happening, I think it's worth doing. So it's critical that we know why we're doing it, what the questions are, and why the trial will answer those questions. We have to, as I've hinted and as Helen has pointed out in terms of teamwork, we have to know what we're doing, not just individually, but as a service. The whole team has to know what they're doing to do the trial. And we need to know with whom we work. If you're doing a drug trial, it's clear you have to involve the pharmacist because they will be dispensing the drug. And I'm guessing in almost every country in the world, the vast majority of drugs are not given by doctors, they're given by nurses or by the patient themselves. We use the laboratories to get the blood tests to decide what drugs can be given safely or when not to give a drug. We look at responses, whether it's in neoadjuvant therapy or in metastatic disease, for whom the results of which we get from the radiologists. If we choose to put a patient in a trial because they are, for example, node positive, we trust our pathologist to give us that answer. We rely, when we sit with a patient either thinking about a trial or in a trial, we rely on a whole team of people who are giving us information which we use to put into the patient and into the decision-making process. And if we don't engage them in the process of the trial, it will not work as well. And some work has been done in the UK by Leslie Fallowfield looking at how multidisciplinary teams discuss trials. How does the whole team handle the question of a trial? Now, I should have asked someone this question, but I don't know. I don't know how commonly in your surgical clinics you have what we call breast care nurses, who are well-experienced nurses whose job is to help the patient through the process of being diagnosed with breast cancer and being treated with breast cancer. And I was conducting a trial with a colleague, a gynecologist, looking at the effects of chemotherapy on ovarian function in premenopausal women, trying to collect sequential blood samples looking at AMH, anti-Müllerian hormone, HCG and other things, to understand how we could predict which patients would become amenorrheic during chemo. And very few of the women were going into the trial. And I couldn't understand why, because it was only involving a couple of blood samples before surgery and then one every 6 months. The breast care nurses didn't understand why we were doing the trial. And they were telling the patients, not don't go in the trial, but they were not supporting and encouraging the patients in the decision-making process. We sat down with the breast care nurses, explained the purpose of the study, and they went, we understand. And suddenly the recruitment took off. It was nothing to do with what I was saying. It was information they were getting from other people in the team. We have to understand with whom we work when we try and deliver research. And we must also understand what it is they don't know. And that example of the breast care nurse is a classic one. She, or rather the team of them, didn't understand why we were doing the research. Once they did, they supported it. So, one of the things you have to do, everywhere in the world, is to get ethical approval for the trials. Some countries have centralized systems, some rely on their own institutional review board. And interestingly enough, ethics doesn't talk about how nice we are to the patients. It only talks about the ethics of doing the trial. But we have to share with our patients why this research, we believe, matters. and I think they're much more likely to take part. Second thing, and Helena said it, and I will say it a few times, we must not try and do clinical research on our own. If we're fit and strong, we can cross the Antarctic, maybe. But to do clinical research entirely on your own is likely to lead to a disaster, or having to work 36 hours a day, which is likely to lead to a disaster in ourselves or our families. This is about teamwork, and I really, really want to stress that. I'm delighted to hear over the last 48 hours the enthusiasm to do research. But many of the people who will be doing the research are not in this room. We need to bring them in, respect and recognize their contribution, and then your research will fly. So, you need to run the central part of the trial. For an EORTC trial, it's the EORTC headquarters, a central team who handle all the data. They will have trained data managers whose job is to very carefully record the data, usually in a computer database, check the data, look for errors and inconsistencies. There is a chief investigator, usually the person who designed the trial, although increasingly trials are designed actually with groups of people. The chief investigator takes the responsibility for the trial, and in Europe actually carries some legal responsibility. And it's important that the chief investigator recognizes that they are the figurehead of the trial. Part of the job is to persuade other people that this trial is worth doing. What we would say in English, you would use up shoe leather, going around hospitals, talking to investigators, talking to research teams, selling the trial, so others share your enthusiasm for doing the study. If you simply design a trial and sit in your office, I suspect it will not recruit as well. One of the most important people is the statistician. We may have brilliant ideas for trials, but unless your methodology, the method by which you're going to answer the question, and the statistics, which mean that when you get an answer, you can be confident that it's a real answer, if that is not right, it's likely to fail. And the medical literature is full of small trials that are either too small to answer the question or use the wrong technique. So the question was really important, the research is done, and the question remains really important because the trial didn't give an answer. Now that's partly why we are increasingly doing multinational trials, because we need more patients to get to a robust answer to the question. And you need a sponsor, particularly for drug trials in Europe, you need a named legal body that carries the ultimate responsibility for everything in the study. And that's important because they have an oversight to make sure the conduct of the research is as good as it should be. But equally, you need your local team. You need a named local principal investigator who takes responsibility for what happens at that hospital. And they work with the people who do the real work. In Europe, it's often research nurses. Here, I understand, in Egypt, it's often junior doctors. It doesn't matter. They do most of the work. We need to train them, support them, and recognize them. You'll have data managers, you'll have colleagues. We need to learn how to share our trials so that if I'm conducting a trial, I want my patients to put my colleagues to put their patients into the study. No point in me running one trial and my colleague running a completely competing trial, because neither will recruit properly. So we increasingly try and work with colleagues to persuade the whole department to support the trial, even if one person, this time, is the principal investigator. And the labs, the radiologists, and any other department in the hospital that is involved in the trial, bring them on board. Spend a few minutes on the phone or walking down the corridor. So they understand why you're doing the research. They're much more likely to help you do it. And then there's all the bureaucratic legal process, which I've called R&D and governance. It matters. Get it right, and it isn't usually a problem. So in the central team, we have to remember something. So the EORTC headquarters designing a trial. A trial is an experiment. It may involve old drugs or old treatments, so the risk to the patient is minimal. But it is still an experiment. Now, if you're designing a laboratory experiment, you control the conditions very carefully. If you're growing cells in a flask, you make sure there's no infection. You control the nutrients. You control the temperature. You control the air, CO2, oxygen, etc., etc. Because that way, when you see something happening in your cells, you know it's what you did to them, not the fungus growing in or the mycoplasma, which causes the problem. And we have to remember in a clinical trial, especially if it's a randomized trial, the same principles apply. Not everybody is eligible for a trial because we need to control the patient group so that the ultimate difference between the two randomized arms is only the difference in treatment, not the fact that they're different ages, different cancers, different stages, and so on and so forth. And so working out how you do that, the methodology, the experimental design, often requires experts who are not clinicians. Methodologists or statisticians, they're called. And they can make a huge difference, and I can speak personally. Having a trial idea and realizing that sitting down with a methodologist turns my idea into a reality that doesn't look like what I thought it should have done. Because my idea was wrong. Not the question, how do you treat this, but how you do the trial. And critically important, especially with drug trials, is what we call safety. I mean, all the ethics and legislation about doing trials in patients is first comes safety. We have complex safety reportings in Europe. If you haven't yet got them in Egypt, you will. Because increasingly the bureaucracy around reporting incidents of patients in trials and understanding the safety data to make sure that we're not doing patients harm, or at least not doing more harm than is justified by the research, is a critical component. Pharmacovigilance, the responsibility of the investigators, the sponsor, etc. It's important. And increasingly, I suspect everywhere in the world, it'll become more bureaucratic, but it's for a good reason, however frustrating the bureaucracy is. You need to plan the campaign. Now, the statistician will tell you you need so many thousand patients, you've got to recruit them in this time frame, and I'll give you an answer after you're retired. Okay. But then you say, well, if we go to more countries or more centres, can we get the answer earlier? But if you then sit back and do nothing, you will not get the patients in as quickly, very often. So you need to think about the whole process. So make sure that your protocol, the design, the methodology is something we can do. If necessary, you do feasibility, as we did in MindAct. Do a small version of the study. Does it work in real life? Do feasibility. Go out to centres, and anybody who's taken part in a183i studies will see this regularly. We send out feasibilities to understand how many patients you are likely to recruit. And whatever you tell us, or whatever I tell the a183i, they halve the number, because we always overestimate. And if we recruit more than we say, it's a bonus. If we recruit less, and the whole trial is based on us recruiting what we said, the trial is in trouble. So understanding the process. You then need to get funding, whether it's from a grant application or a company, and that often involves quite a complex process. They're very different. You may have to sell your idea to a company. That might involve quite a lot of work. And then there's all the process of starting it up, start-up meetings, explaining to your colleagues what's involved, so everybody's ready when the trial starts. And as I said, we should not just be doing drug trials. There are other treatments to use, but increasingly we're interested in other factors. Helen talked about them in terms of sub-studies within Amoros. What's it like for the patient? We think this new treatment, this doing something different, is wonderful. And actually, we discover in the end sometimes that it's not any better than the old treatment. And then we suddenly realize we've forgotten to ask the patient which they preferred. Because patient preference may be an important treatment decision. So if during the trial you can collect quality of life, information reported to you by the patient, you enrich your trial, so even if the answer is negative for the new treatment being better, you may have very good information that it's easier, better tolerated, or whatever for patients. And increasingly, as I said before, and I think we're all seeing, we want access to tissue samples from patients, either their cancer, sequential blood samples, whatever, to understand better the biology of the disease and the effect on that biology of the treatment. And we can do sub-studies. What's the effect of this new treatment on osteoporosis? What's the effect of this new treatment on cardiac function? As Helen again mentioned in the Supremo study. Not necessarily in every patient. You may not need that numbers. But in certain centres, you can focus on specific questions. And I can imagine situations where different countries will address different questions because the sub-study question may be more important in one country and a different question more important in another. You've designed your trial, you've persuaded your team to do it, the patients enroll, the central data center looks at all the data and gives you an answer. What do we then do? Hopefully publish, but ultimately we did this trial to help patients. And so the final step is, how do you implement the trial into real life? And so these are sort of suggestions rather than dogmatic statements. Well, one of the reasons I think doing research is good for the whole service is because you standardize what you do. In a trial, you follow a specific protocol. So very often what we have done is to take the protocol, and if Arm A in the protocol was better than Arm B, we then use the protocol to guide how we introduce the new treatment into real life. Why not? We've just shown it's better. Stick to what works. Not everybody in your service could have gone into the trial, but if it's safe to apply the trial protocol, well, there's a logic to it, because we've just done a trial with that protocol and we understand the side effects. If we start changing the treatment protocol, we have less confidence as to what will actually happen. And then the other important thing, just as thinking about doing the research, who do you need to speak to? When you've got the new result, who do you need to speak to? Do you need your pathologist to do a different or extra test? Does your surgeon have to do his surgery or her surgery differently? Does your radiologist need to do the imaging differently? Do the pharmacists have to make up the drugs differently? You know, you may have spent, sometimes with big phase 3 trials, it can be 10 years of your life. And if your trial gives you a clear answer about what you have to do, your work has not finished when the journal has accepted your paper. Because you then have to work out how to get the trial into routine practice so that everybody benefits. And we all discover sometimes real life is not quite so straightforward as it was running the trial. There's an education process to the colleagues and other departments. You may need to educate your staff about new side effects. Perhaps a good example that came out of this, when we looked at the aromatase inhibitors, we uncovered the joint problems that in fact exist for other endocrine therapies, but were much better documented on aromatase inhibitors. The senior clinicians, both medical and surgical, the junior clinicians, the GPs, the clinic staff, the rheumatologists, all had to begin to understand that we had introduced a new toxicity with our new drug that actually was not really well characterized when the trials reported. And the same will be true as we've introduced many of the new TKIs like Sutent and so on. We're uncovering cardiac side effects we didn't realize were perhaps quite so common as they were in the studies. So putting the trial into real life, you need to warn the other departments of your expertise and be ready to look for the new side effects that emerge. And you need to you need to balance when you use the new treatment and when you don't. It's not for everybody, but it's usually for more than just the patient group in the trial, because trials have a deliberately restricted patient group. And we have to learn how much you can extend the new treatment out into other patient groups. And the patients need educating. We need to learn what the effect of a new treatment is. We also need to share that with patients. Because in my experience, patients tell doctors much less than what they tell nurses or their friends or the patients they've met during the treatment program. They tend to selectively tell doctors what they're experiencing. And if we don't warn them of new side effects, they may think it's nothing to do with us and go off and discuss it with somebody else. So there's an education need, and there's an expectation about what the new treatment does and doesn't do. And, having done the trial, there will be new questions. And particularly for our junior colleagues coming through, they can look out and ask questions. Well, we've cured these patients, but not these. Okay, so that new drug or new surgical operation has dealt with this. Now we need something else to address. Who are the people for whom the treatment fails? And I think this is terribly important. The trial says A is better than B. Audit what happens. Is it really better in real life? The trial was conducted in the USA. Doesn't mean it'll work the same in Egypt or the UK. It may work better in our populations. We need to follow up the implementation of these new treatments to really understand what they deliver. Sorry to quote an American, but there's some quite important things about clinical research which fit into the Rumsfeld's known knowns and known unknowns. There are clear questions to which we do not know the answer. If we're giving chemotherapy, should we give G-CSF to avoid neutropenia first, or do we wait until we get the neutropenic effect? There are differences for both of them. We don't actually know which strategy is best for curing patients. Studies have been done in premenopausal women. We know chemotherapy induces amenorrhea. What happens if you switch off the ovaries by giving goserelin, an LHRH agonist? Actually, phase 2 studies have been done, but we don't know the long-term benefits or harms to patients. These are questions we know exist and don't know the answer. Some of the more interesting things to think about are the things that we didn't know we didn't know. I have a colleague who in ovarian cancer made an observation which is now published as a result of collaborating with colleagues. He worked out that his ovarian cancer patients with liver metastases very commonly had a family history of breast or ovarian cancer. That is now documented and published as being strongly associated with having BRCA1 mutations. That was unknown 10 years ago, because the natural history of the disease has improved, and now these things emerge. There are other things like that sitting in our clinics that we don't know, that we haven't understood. Another colleague of mine put a sarcoma patient into a phase 1 study, and it was an astounding response from a drug that nobody had even thought would work in sarcomas. There's now a phase 2 study that he and a colleague with the company are pushing through the URTC. These unusual observations may be sitting on a huge piece of important clinical information that can be tested in a trial. Finally, just realised I haven't changed the slide in the way I meant to because I've got English data here. How we deliver our healthcare service is a huge unresearched area. Interesting, isn't it? We spend a lot of time testing drugs, a bit of time testing surgery, radiotherapy. We don't test models of healthcare. And this is a growing area of research interest across the world. Actually, how we deliver healthcare can sometimes be more effective than what healthcare we deliver. And particularly in financially challenged circumstances, which includes most of Europe, and sadly Egypt as well, maybe we need to think, what is the best model for doing the best model for doing healthcare, not just the drugs to use. Sorry, I just realised that was an old version of the talk, because I took out the last slide and put a new one in, and I obviously haven't put it up. So in conclusion, doing research is a team activity. It's about understanding the question, looking out for new questions, building the team with the data centre, with the statistician, with colleagues, conducting the research, bringing everybody on board, and then when you've done the research, then looking to see how you implement it in your own health service, which again involves bringing everybody on board, persuading them that you want to change the way we do something because the trial shows it's better, and actually working out all the steps and parties involved in doing that. Thank you very much.
Thank you, Professor Dave, about this elegant presentation about how to improve outcome via research implementation. And I think we are behind our schedule by 30 minutes, so we'll stop here and we will move to our next session, Charlie. Thank you very much.